Okay, it's recorded. Okay, so we finished up palm. I don't want to do that. And now we're going to move on to derm. Hopefully everyone had a good lunch because there's a ton of lovely pictures in this one. So we'll get started. So I put this picture. This is when Eli was 6, but the reason is, as you're studying, and when you get to like group study, if you could explain something as if they were talking to a 5-year-old, he's 6, I put 6, but as if they're a 5-year-old, then you really understand what you're studying. That's why group study works well, because you're talking to your partner. They may not be great in one area, but you are, and you can explain it to them and so forth. So if you have a really good understanding of things, you can explain it to anyone. So today we're going to talk about the functions of our integumentary system, the layers of the skin, talk about some pathogenesis as well. So start off with just our normal skin. Obviously, skin is the most accessible organ in the body. It covers our entire body, obviously. Protective function. All skin diseases can be observed clinically, so all you have to do is just look. So if you work in a derm office, if you're doing a skin evaluation, they have to strip down. You have to examine everything and see what's going on. Functions include maintaining body temp, barrier against invading organisms, external stimuli, we went all over that in neuro and physio, and controls insensible water loss. This is very important because when people in thickness burns and they lose a lot of area of skin, they're at risk of losing a lot of water as well. Very dehydrated, hypovolemic shock with these severe burns over a large part of their body. Anatomy of the skin, it's only about 1 to 4 millimeters thick. Obviously, all exposed area. Skin is distinct from mucosa, okay, because the skin has adnexal structures like eccrine units, sweat glands, hair and oil is from the skin. The mucosa is your mouth, the inside of your mouth. So there's a difference in what is skin versus what is mucosa. We talked about also variation in skin thickness and composition. That tells us again, remember sensitivity. We don't have very many pain receptors in the antecubital spot, so it's a good place for needle stick. Talking about remember 2-point discrimination, the fingertips, 1 to 2 millimeters of difference, but the back of your calf is 40 millimeters of difference of 2 points before you sense that there are 2 points. So again, depending on what's going on with the body, the thickness, and so forth, what's going on. Size of the structures, obviously we have hair growth in some places, in some areas we don't. So when we look at the layers of the skin, we break them out into different layers. We have the epidermis, the outermost layer, superficial, tough, protective, has stratified epithelium, and they have what's called keratinocytes. So keratin. Okay, also has melanocytes here. Okay, so pigmentation, out in the sun for too much, melanin comes out to darken the skin. Epidermis, has 5 layers. Then we have the dermal layer. There's this epidermal junction. It's an undulating basement membrane. Basically, the dermal layer separates the dermis from the epidermis. And the dermis, semi-fluid, binds the body together. The dermis is where the tattoos go. They're in the dermis layer, not in the epidermis. That's why tattoos never go away, because the epidermis is always sloughing its skin and regenerating, but the dermis is constant, and those pigments get lodged in there and they stay there. So here's another way of looking at. We have the cornified layer, stratum corneum, that cornified your keratinocytes. The next layer of the epidermis is the stratum granulosum. This is that granular layer. So when we talk about skin healing, when you get a scab or a scrape and that skin has to heal, it's called granulation. It's new skin growing and it's very itchy. So when you have new skin growing, that itchiness that you feel, you want to constantly pick that scab, it's just new skin growing. It's granulation. It's from the granular layer. Then we have the spinous layer. They have these desmosomes there. Again, spinous layer. Basal layer is that dermal layer. It's the whole light purple section undulating between the dermis and the epidermis as that final layer. Here's another way of looking at the skin. Again, all the different areas. I'm not going to ask you what this does or sensory issues and those things. Just know the layers. Epidermis, the different layers of the epidermis, the dermal layer, and then we have the dermis underneath. Histology of the skin. Melanocytes and Langerhans cells. They're dendritic cells that are intercalated. Melanocytes are in the basal layer and they synthesize melanin. Okay, so that's why you get tan with sunburn. It's a protective mechanism against the UV rays. The Langerhans cells are from bone marrow and they have antigen presenting cells. So obviously these are your immune system. Okay, dermis, connective tissue of tissue gel, a lot of proteins, mucopolysaccharides. It serves as the scaffolding, so it's a support structure. The dermis provides the support for all those neurovascular networks. Has collagen, elastins there, all throughout the dermal layer. As we get older, the elastic properties go away, and that's why the skin gets saggy, stretchy, wrinkles, because the dermal layer, the scaffolding, the collagen, goes away with aging and the wrinkles start. Okay, let's talk about skin diseases. When we talk about skin diseases with with derm, there are three ways they can present. As an inflammatory process, so just inflammation's going on. It can be infectious, or it could be neoplastic, it could be cancerous. So those are the three general overarching terms for derm diseases, either inflammatory, infectious, or neoplastic. Okay, this is going to be all of you guys tonight. Well, maybe not tonight because you got ENT tomorrow, but maybe when you start studying all these things. Okay, so first thing we have to do is define all of the derm lesions. So the next bunch of slides are all going over all the different derm lesions. So a macule, and that's a picture of what a macule looks like. Increased or decreased pigmentation without elevation or depression. So if you're rubbing your finger over these lesions, you will not feel any rise in skin. It just blends right through. Macules are less than 1 centimeter in size. They're not palpable and only in the superficial layers of the epidermis. So that's a macule. A patch is just a very large macular type lesion greater than 1 centimeter in diameter. That is a patch. So macule and patches. Macules are less than 1 centimeter, patches are greater than 1. Okay? A papule, that's right there. Superficial solid lesion, it's solid. Okay, less than 1 centimeter in diameter is a papule. Often occurs in clusters and it can accompany rashes as well. So that is a papule. Etiology of papules. They can be due to inflammation. It can be due to accumulated secretions. So basically these are your acne or pustules or papules. Pustule just means it's filled with pus. Infection, hypertrophy of skin cells, and obviously there's your acne. A plaque. Plateau-like elevation with a surface area greater than the height. Meaning, if you rub your finger along that rash, that plaque, your skin would be like this, it would be rise and it'll go back down. It would be you would feel this on your skin when you're going across it. What they're saying is that the height here, obviously the surface area is going to be a lot bigger when you look down on it. So the width of a plaque is going to be a lot greater than the height of the plaque. That's all it's saying. And theirs are frequently formed by confluence of papules greater than 1 centimeter in size. So they all kind of come together and then they pop, and then you're left with one big area that's exposed. Plaques can also look like lichenification, lichen, like plant surfaces. Rough and thickened, accentuates the normal skin lines. You can see there, you have your normal ridges in your skin. With lichenification, they're more pronounced. You can see those lines a lot clearer as that skin gets more thickened and rough. Resembles tree bark, so it looks like tree bark. Associated with pruritic disorders. What is pruritic or pruritus? Itching, so itching disorders. Chronic eczema, atopic dermatitis. Over time, again, left untreated, can present as a plaque. This is a vesicle. These are small, fluid-filled lesions. So before we learned about nodules, nodules are solid lesions. Vesicles are fluid-filled. And vesicles are less than 1 centimeter, circular usually, and they're usually filled with something. A bulla, greater than 1 centimeter, but it's the same thing. It's a collection of fluid. It's just a really big size. So bulla is greater than 1 centimeter, and you have your vesicle is less than 1 centimeter in size. Pustule is a vesicle or a bulla containing purulent fluid. We call it a pustule. White head, because it's got white blood cells inside of it, making that white fluid. Superficial skin cavity containing that purulent exudate, maybe yellow, green, white, or hemorrhagic, depending on what's going on with the skin at that time. So those are pustules. Blisters, so both vesicles and bullae can be called blisters. Blisters are a defense mechanism of the body. Basically, the dermis layer and the epidermis split just from constant friction back and forth, and then they split. If you ever notice in the morning when we give you your papers for your scratch paper, when they get too stuck together, to get them apart, you rub them back and forth and they split. That's what a blister is. And where do blisters form? In areas of high friction. Back of your shoes, rubbing that ankle, the back of your ankle, repeatedly all day. From wearing new shoes, that constant friction will cause the two layers to separate, and you get a blister formed from that. So chemical, allergic reaction, physical injury, your friction is there, and so forth. Those are blisters. Nodules, solid circular lesion greater than 1 centimeter, and these usually invade the epidermis and the lower dermis as well. So these are nodules. These are wheals, okay, also known as urticarial exanthem or just plain urticaria. Again, allergic reaction causes these wheals to form. Round, flat-topped edematous, so they're going to be redder than the skin around it. Well demarcated, so you have nice borders. You can see how you have a nice border around the entire wheal. That's the demarcation. There's no scaling going on. It's just a normal skin. There's no dry skin, no flaking going on, no scaling. No epidermal involvement. Color can vary. And the wheal itself can be in different shapes. They can be round, oval, gyrate, serpingeous. And we'll show you pictures of those in a second. With regards to wheals, there are a couple of allergic responses. Emma, our friend, can do this. She has this. So there are a couple of things. One's called derriere sign, where you rub or stroke the lesion, followed by local itching, erythema, and wheal formation within 2 to 4 minutes. That's derriere sign. You're scratching on the skin. It causes the reaction to occur. Dermatographism is just writing on the skin. That's dermatographism right there. Again, things that are going on with these wheals. Here's a cyst. This is a ganglion cyst. These are on top of the wrist there. Encapsulated lesion filled with fluid or semi-solid material. It's going to be elevated, circumscribed, so it's in a round shape, palpable. You can feel these cysts. Enclosed sac. I'm sure you've all heard of the way you treat these things. Take a book and just smack it on the wrist, and it pops the blister, ganglion, and it goes away. You just take a book and smack it. It works. Abscess. Collection of pus. You can see this is a by the gum line. Here's probably ingrown hair or something going in the back there. Some of you who enjoy pimple popper, I'm sure are wanting to squeeze that right now. That was like the one thing that almost made me pass out when I was a student, was like watching this stuff. I didn't like it. we had a sebaceous cyst on the forehead, on the scalp, and she lanced it and then squeezed it, and it shot like cottage cheese like across the room. So I was like, yeah, I'm done. I'm good with derm. I'll go to cardio and work with this stuff. Crusts. Okay, crusts are like scab formation. It's dry blood. Blood will appear brown. Serum is honey colored. So honey colored lesion, you'll learn later, it's called impetigo. It's always a honey colored lesion. Pus will be a combo of yellow and green. You've all had scratches and bruises and scrapes when you were kids. You got yellow and sticky afterwards, and then it finally dried out over that. Yes?
How is an abscess different than a pustule? They're both a collection of pus.
Yes, both full of pus, more location. Also present after blisters rupture, because they have all this exposed layer of skin underneath it, and they can cause problems. This is scales, also known as desquamation. Abnormal areas of the stratum corneum. Okay, so this is epidermis. That's where the stratum corneum is. Increased rate of epidermal cell proliferation, causing these scales to form, or desquamation. Maybe adherent or loose, and they can just peel off your skin. Kind of like a sunburn. When it heals up, you can peel your skin off of you from that. Erosion. This is what erosion looks like. Skin defect with loss of epidermis only. That's what an erosion is. It does not go into the dermal layer. It's just an erosion, just of the epidermal layer, and this will heal without a scar. As long as you don't get into that dermal layer, your skin will heal. But if you get into the dermal layer, then you start getting scars, because the way the dermis is made. This is an ulcer. The ulcer is a loss of the epidermis and the upper layer of the dermis. This is ulceration. Okay, may extend to lower areas, but ulcers will always heal with scar tissue, because we got lower into the dermal layer. So that's what an ulcer is. Telangiectasias. These are basically little spider veins or vessels that pop up. You think of like alcoholics, their nose gets big and they have all the veins pop up on their face. That's a sign of chronic alcoholism. There's some other things that present with telangiectasias as well, but basically they're just small, enlarged blood vessels near the skin. Very, very small in size, usually on the nose, cheeks, and the chin is where you'll see these telangiectasias, just little blood vessels that they're enlarged and they're on the surface of the skin, so they show up. You can see them right there on the bottom right corner of that picture. Petechiae. One petechiae, small red or purple spot on the body, less than 3 millimeters. What causes petechiae? Minor hemorrhages, broken capillaries. If you've ever had had too much fun on Friday night or Saturday night, and you wind up getting sick. Some people, when they vomit very hard, they will break the blood vessels in their face, and will causing petechiae just from the act of vomiting. The pressure builds up so much, they rupture and they cause petechiae. Thrombocytopenia and decreased platelet function. Purpura are the same thing, they're just bigger. 3 to 10 millimeters in size now. Etiology for purpura, bleeding under the skin. So, bruised. It's basically a bruise, yes.
For petechiae, will those ever go away? Or
No, they go away.
If they stay for
They usually will go away. I mean, they're just small burst vessels. The body will reabsorb them. Purpura is a bruise, just in a bigger area. So 3 to 10 millimeters in size for purpura. So here's an example of petechiae versus purpura. It's just the size. That's all. The size of the lesion. This is ecchymosis. Is there obviously just a really severe trauma or a bruise greater than 1 centimeter in diameter. So petechiae, purpura, ecchymosis, pretty much all the same thing. You're just getting larger in surface area of the size of the lesion. Petechiae is the smallest, purpura is in the middle, and then ecchymosis is the biggest one, usually blunt trauma. She probably got into a car accident or hit something and that caused all that bleeding to happen. So that's ecchymosis. Petechiae versus purpura versus ecchymosis. Again, this slide kind of shows you the different sizes of the lesions. However, they do not blanch with pressure. You'll put your finger on these lesions and you'll push down on them. They don't go away like cap refill does. They will stay there. So it's very important with derm lesions that you want to feel these lesions. You want to see if they're raised or not. You want to feel if you blanch them, do they blanch? Do they go away as you push down on them? These will not. They will not go away because it's in the skin. Tumors are also involved with derm. Solid lesion, elevation and depth, usually involves epidermis and the dermis, maybe some subcutaneous tissue. Greater than 2 centimeters in diameter is considered a tumor. Tumor does not mean cancer, it just means abnormal cell growth. You still need to biopsy it to see if it's cancerous or not. Okay, may or may not have some pigmentation with it as well, but those are what a tumor is. It's just a collection of cells. Does not mean it's cancer or non-cancer, it's just cells. So this last one is more definitions as far as talking about the margins. Sharp margin versus ill-defined margin. Circinate is circle. Arciform, they look like an arc, these lesions. Annular or iris, these are talking about target lesions. You'll see them called target lesions. They look like targets. Okay, so when later on you'll see, we'll talk about target lesions, and we're talking about annular or iris lesions. Serpingeous looks like a snake. That's why it's called serpent. Serpingeous, snake-like. That's another type of reaction that can happen. Gyrate, just gyrates all over. There's no real pattern to it. It just kind of goes all over. Linear. We're going to talk about some derm patterns that have a linear pattern of disease. Okay, or is it zoster form? What is zoster form? Anyone have an idea? What are we going along what? Dermatomes. Zoster form is referring to dermatomes. Okay, we know all your dermatomes. You guys had to do them all in your neuro exam, right? C1, C4, C5, T10, whatever. Okay? Shingles comes in a zoster form pattern. It only erupts along that dermatome. Herpes zoster only goes along a dermatome. That's why you have to be careful, especially with like ophthalmic division of your trigeminal nerve, because that gets infected and you get into your eye. So that's why it's very important to know those dermatomes, know where they go, because that's the pattern they're going to have for their rash. So this is what serpingeous, this is what hookworm looks like. So hookworm comes in a serpingeous pattern. That's the biggest thing for derm is remembering the patterns of their diseases. So here's another guide for you as far as the different lesions of the skin. Also on Canvas, there's another cheat sheet on there for you with pictures of lesions of the skin. On your exam, there are no pictures. It's just going to be describing these lesions. So there's no pictures on your exam. But the question on your exam is, like, you see a raised nodule that only measures 0.3 centimeters in diameter. what is it? Is it a nodule or tumor, whatever. Stuff like that. It'll be questions like that. You see this lesion, it measures 0.5. Is it a patch or is it a macule? Those are the type of questions you'll have. Okay. Oh, you darn people. Okay. Okay, so types of inflammatory skin diseases. This is pretty much all we're going to be focusing on in this class, are the inflammatory skin processes. They have different structures within the skin that they affect, display different microscopic patterns. There's only 9 of them that we have to worry about. Of these 9, we're going to go through what diseases fall under this category. So we are going to associate the diseases, but we're looking at it from what disease process is going on first. So we have perivascular dermatitis. An example of that is hives. We're going to go through this all in detail. Don't worry about it right now. We're going to go through spongiotic dermatitis, and this is an example of allergic contact dermatitis. We have psoriasiform dermatitis, and this is your psoriasis. We have interface dermatitis, and this is lichen planus. Vesiculobullous is your bullous pemphigoid, and vesiculitis is leukocytoclastic vesiculitis. And the last 3 that we're going to go through in detail are folliculitis, and that's acne, nodular dermatitis, which is cutaneous sarcoidosis, and the last one is paniculitis, which is erythema nodosum. So when you're studying this, know the type of inflammatory process, and then the disease will go along with it. So this is a good summary slide as far as all 9 different types. We're going to go through each one in detail. So this is just a good summary slide, and we're going to start. So the first one is psoriasis. The pattern for psoriasis is psoriasiform dermatitis. And we'll see what happens with the skin when we get there. Psoriasis is a common, chronic, persistent, or relapsing scaling skin condition. So they're going to have scales. Okay, sharply marginated. So what does that mean? Very clear borders. Erythematous. What does that mean? Red. And surrounded by silvery scales. So if you see anything with silvery scales, think psoriasis. And many patients with psoriasis will have a limited number of fixed plaques. So there'll be certain areas that are going to be affected by the psoriasis, and those are the only areas they'll be affected by it. So this is what psoriasis looks like. Okay, epidemiology, 1 and 2%, both sexes, most ethnic groups. Onset, 3rd decade. There are some genetic factors that have played a role with this. As far as etiology, still unknown, probably some multifactorial stuff. Infection, injury, maybe, some genetic thing going on as well. So again, silvery looking plaques is psoriasis. Psoriasis is characterized by epidermal hyperplasia, so skin is getting thicker. Elongation of these rete ridges. Psoriasis is really the only one that affects the rete ridges. We'll talk about those later on. Thickening, clubbing, and fusing of those rete ridges, thinning of suprapapillary plate. They may get what's called squirting dermal papillae. These neutrophils are in the area, get stuck inside there. Inflammatory cells and perikeratotic hyperkeratosis, so getting more thickened skin. So this is your healthy, this is your psoriasis. Again, look at it. It's only affecting the epidermis, right? Just that top layer is what's affected with psoriasis. Silvery scales, they fall off. You can peel these off, you'll test them. And you go through more detail with this when you get to derm. Clinical manifestations of psoriasis. They can affect the nail bed. So have pitting nails. Okay, they can occur at any site but the scalp, extensor surfaces of the extremities, and flexural surfaces are most often involved. Again, it can also affect the nail bed, which is what we see here. Mucosal surfaces are spared. So where will you not see psoriasis? In the mouth and in the anus. Remember, the anus is mucosal tissue as well. So that's psoriasis. Now, there's an error form, which is an extracutaneous manifestation of psoriasis, psoriatic arthritis. Okay? It's a deforming, asymmetric, oligoarticular arthritis. So it's going to affect one joint asymmetrically. The most commonly ones that are affected by psoriatic arthritis, distal interphalangeal joints of the fingers and toes. Also known, psoriatic arthritis is a seronegative spondyloarthropathy. What does seronegative mean? So when you guys get to rheumatology next year with Dr. Ovalle, you're going to go over these type of things as well. A lot of the arthritises that you're going to read about, they have antibodies or other things in the blood that will give you the reason for that problem. With psoriatic arthritis, it's not going to have any serum issues. There's no antibodies that's causing the issue. It's not an autoimmune problem. It's just localized to that joint. So they're not going to show up anything on blood dealing with psoriatic arthritis. The next one is interface dermatitis. And this is interface because the interface between the dermis and the epidermis is obscured. Remember, we have that nice dermal layer there, that basement membrane between the epidermis and the dermis. That's all obliterated now. Lymphocytes attack the basal layer of the epidermis, causing vacuolar change. What is a vacuole? It's an empty space, like a vacuum. So we'll talk about vacuoles in a second. The main one is lichen planus, also known as chronic interface dermatitis. There's the acute form of this, and that's called erythema multiforme, which is the acute version of interface dermatitis. Obviously, we'll go through reasons for that in a second. So interface dermatitis involves T-cell mediated damage of your keratinocytes and remodeling of that basement membrane zone. Remember, that basement membrane is the dermal layer that separates the epidermis from the dermis. When you injure these basal keratinocytes, they produce tiny vacuoles along that junction, also known as vacuolization, vacuolopathy, and liquefaction degeneration. They all mean the same thing. You're destroying tissue and it leaves a hole in there. We'll get to this in a second. Lichen planus, again, is the chronic one. Adulthood, more women than men. Etiology mostly unknown, but there are some drugs that can cause this as well. So if you're giving your patient any of these drugs, your thiazide diuretics, okay, and they start getting some skin issues, stop the medication. They're having a reaction to it, causing this interface dermatitis. So a lot of drugs have this reaction. Lichen planus begins with dense infiltrate of our T lymphocytes in the dermis and superficial dermis. It damages them. We get these vacuoles that appear in the lower epidermis. You may get some colloid bodies there as well. And they're going to have CD8 cells, not CD4. Which cells have CD8s on them? Yep, killer T cells. Lichen planus. Here's your linear dermatitis or lesion now. We talk about linear, how to describe how it looks. Linear patterns. So they get a pruritic eruption, so it's going to be itchy. They're usually present bilateral and symmetrical. Borders are angular or polygonal. So the borders are like that. If you were to put your finger over these lesions, it will feel like that, flat-topped. Violaceous in color. So they're going to be purple streaks. Okay. Solitary lesions coalesce to form longer plaques, and that gives you that linear appearance to it. And these are also known as Wickham striae. They have very, very minute white streaks throughout them. If you look closely, you can see a little bit of white in there. Those are the Wickham striae found on lesion surfaces. Very difficult to see, but you can kind of, if you look, you can kind of see a little bit of white sprinkled throughout that purple lesion. Those are the Wickham striae. Where is lichen planus going to occur? Flexor surfaces of the extremities, genital skin, and mucous membrane. So now we do have some mucous membrane layer involvement. So lichen planus can go to mucous membranes. Psoriasis will not. It's only the skin, not mucus. Lichen planus can go to both. And this is what lichen planus looks like. Some different examples. Okay. Erythema multiforme is uncommon, but again, it's the acute form of interface dermatitis. Cell-mediated immunity, necrosis of epidermal keratinocytes. So it's just necrosing all the skin. I'll show you some pictures of that in a second. What can cause this? Herpes simplex infection, reaction to meds, or idiopathic. So these are your erythema multiforme, target type lesions. Okay, all those lesions are circular, annular, and sometimes they have dusky centers. That's called a target type lesion. Physical exam, cutaneous eruption to the skin or mucous membranes. It'll be brief and self-limited, which means it's going to do its thing and then it'll go away on its own. Lesions developing crops on the acral surfaces, so distal portions of your limbs, can reoccur and it can be life-threatening. Prototypical lesion is the monomorphous pattern, red macule or a thin papule that expands from the center and outward. So it starts off like this and then it starts to expand outward, giving you that target-like appearance. Starts in the center and works its way out. As it's working its way out, all the tissue inside dies. Remember, this is necrosis. That's why the redness spreads out and the inside gets lighter in color, because that tissue is dead inside. It becomes necrosed. So the center becomes dusky or necrotic, and we call them target-like lesions. That's erythema multiforme. Pathogenesis, again, sparse infiltrate from inflammatory processes causing necrosis of your skin cells. When that necrosis occurs, that causes that vacuole to be developed. It's basically just a hole. Nothing's inside because necrosed the tissue, dead tissue, doesn't take up any more space, and it goes away. We get CD4 and CD8s are here. Mild cases have been triggered by just your herpes simplex infection, target-like appearances. There are two different forms of erythema multiforme. You have a minor type and a major. The minor, scatter lesions, limited mucosal involvement. Then they have the erythema multiforme major. And this is prominent involvement of at least two mucosal sites, oral, anogenital, or conjunctival. So your eyes, the inside of your eyes is mucosal membrane. If you have two of the three of these areas involved, then it's called erythema multiforme major. Yeah, I got pictures. So erythema multiforme major severe, widespread cutaneous involvement. There are two types of erythema multiforme major. The first one is called Stevens-Johnson syndrome. Mucosal involvement plus or minus cutaneous lesions, so more mucosal. Then the last one is toxic epidermal necrolysis, TEN. Cause, drug reaction. Large areas of skin mucus become necrotic with secondary vesiculation. Most likely medications is what cause these things. They're going to treat them like a severe burn. And when you see the pictures, you're going to be like, oh yeah, that looks like a severe burn. But it's really this toxic epidural necrolysis causing this appearance. So this is your Stevens-Johnson. If you look at his mouth in this picture, you can see all that involvement in the mucosal layers. You can't see his eyes, we don't know, but obviously severe skin necrosis going on. This is Stevens-Johnson. Here's your toxic epidermal necrolysis. That looks like a burn. And you treat them as like a burn victim, but it's not. Remember, all the integrity of that skin is lost. You're going to lose fluid. High risk for infections. Now you have exposed skin to the air. So you treat those patients like a burn, yes?
How long would he have to take that medication or be like that?
I don't know how fast the reaction can occur.
Okay.
But obviously this doesn't happen overnight. This is going to, over a couple of days, it'll get worse and worse, then you wake up and it's like really bad. But obviously go right to the ICU and stay there until you're better, yes?
My niece has Stevens-Johnson. They switched her. She got a little bit older, so they switched her seizure medication, and it was 2 doses, and she looked like this guy, but she looked like that all over.
So we go back to the meds that can cause this. I'm pretty sure Kepra's on there. Anticonvulsants, there you go. Yeah.
Can Stevens-Johnson syndrome progress to 10? Is that like how that works, or are they separate?
I think they're separate. It has to do with the mucosal involvement. And then you differentiate the two. Okay. So those are the two. Okay, let's take a break. Come back at 1:20. Okay, we'll get started. Okay, so we're moving along to the next few types of patterns of skin diseases. The next one is vesiculobullous. So it's got the word bullous in it. So bullous pemphigoid are the main one it's going to be. So look at the name. It's going to be there. Bullous is what's going to happen with this one. So a bullous pemphigoid is a blistering disease in which tense fluid-filled spaces develop within the erythematous, inflamed skin. So we get red skin with these very tense blisters. When they say tense, it means that they're filled with a lot of fluid, so the skin is very tight over it when you're looking at it. This develops because of the detachment of the epidermis from the dermis. So those two layers split apart. A pemphigoid reflects the clinically similarity to pemphigus, which is another type of bullous disease. So there's bullous pemphigoid and bullous pemphigus. The pemphigus is the more severe form of the disease. Okay, so pemphigus is the more severe form, so you have a better prognosis with the pemphigoid. Whenever you see something that says ends in oid, it means like whatever it's describing. So pemphigoid is like a pemphigus, but it's not totally it. Okay, so etiology and epidemiology, disorderly of the elderly usually, no difference between sexes, and there's some immunoglobulins and complement are here as well. So therefore, bullous pemphigoid is a form of autoimmune disease. And this is what it looks like When you look under on slide, this is the separation right here of the layers. You get all that fluid filled inside. Subepidermal cleft contains numerous eosinophils and lymphocytes. And we get separation of the basement membrane, and that's where the pemphigus is. So everyone see the splitting of the two layers split apart? So this is what it looks like. Large, tense blisters. Erythematous base. All these blisters. This is bullous pemphigoid. Most common on the extremities and the lower trunk. Okay. Also experience pruritus, so some itching going on triggered by the eosinophils that are in the area. Mucous membrane involvement in 1/3 of patients. So you can have mucous membrane involvement with bullous pemphigoid. Clinical manifestations. Some will have that itchy erythematous plaques with no blistering for a certain amount of time. That's called pre-eruptive or urticarial. So urticaria, those wheals. Okay, itchiness, erythematous plaques, no blistering. That's the first thing that's going to happen. So bullous pemphigoid is a disease of the skin and mucous membranes only. Some have developed skin lesions alongside a diagnosis of malignancy, but there's no increased risk of cancer with bullous pemphigoid. But if you have cancer, you may develop bullous pemphigoid. That's what that's trying to say. If you have cancer, you may develop bullous pemphigoid due to the cancer, but just because you have bullae on the skin does not mean that you have cancer. So don't just rule it, don't just think, oh, I see bullous pemphigoid, they have cancer. No, there could be other reasons for it, but that is one of them. The next one is vasculitis. Example, leukocytoclastic vasculitis. Okay, this is an inflammatory disorder affecting the small blood vessels of the skin. This is dealing with the blood vessels. That's why it's called vasculitis. Has to do with the vessels of the skin. And you get this reddish or violaceous pattern known as palpable purpura. These are palpable, which means you can feel them as you're moving your thumb or your fingertips along that edge. You'll feel a raised border. It's palpable purpura with vasculitis. They develop in crops. Again, wherever those vessels rupture, that's where you're going to have that lesion. The more vessels rupture, the more lesions you're going to have. Can develop at any age. Incidence between male and female is the same, but the precipitants, your post-streptococcal and post-staphylococcal. So if they come in with this type of infection, find out what happened. Were they sick beforehand? What happened? What were they going under? And then obviously drugs, penicillins will cause this. Here's your thiazides again. And NSAIDs if they have a reaction to it can cause this as well. Histopathology and pathogenesis. This is, again, inflammatory reaction involving your blood vessels with accumulation of a necrotic nuclear debris. And that gives us that, whenever you see necrotic, think of a dusky, pale color appearance because the tissue is dead. Lesions are raised and papular because the lesional skin is altered and expanded due to all the neutrophils that are going into that area. So it kind of raises the skin up. The inflammatory process needs to be corrected. We have white blood cells get into the area. Okay, the erythematous or purpura quality of leukocytoclastic vasculitis is the erythrocytes that accumulate in the dermis. Okay, we have a reaction here. It's an inflammatory process. White blood cells are going to go to the area and they accumulate in the debris, and that causes the rise of the lesion to occur. Clinical manifestations of this type of dermatological process can be at any site, but mainly your lower extremities. The purpuric lesions are mostly common, but they also have some vesiculopustules or those necrotic papules. Some ulcer formation can occur as well. Often part of a systemic vasculitis involving small vessels. May have some arthralgias, myalgias, malaise with it as well. So there's some underlying infection going on. So that is vasculitis. The next one, spongiotic dermatitis. This is your allergic contact dermatitis. Spongiotic, with a sponge. Eruption is usually pruritic from an immune-mediated reaction to a substance. So immune response to something that's causing it. Again, contact dermatitis, we talked about those delayed hypersensitivity reactions. Okay, cheap jewelry causing a reaction. This is what we're talking about. So the acute phase, erythematous papules and vesicles and bullae. In the acute phase, often those blisters break down. So when they break down, all that fluid starts weeping, and it starts, like if it's on your legs, it'll start running down your leg. So the blisters break, and whatever's inside, the contents start oozing out. Incidence hard to gather since most don't seek medical attention. Okay, you just put some cream on it, prednisone, hydrocortisone cream that you buy at the store. You put it on it and it goes away. The steroids do it. Most people, again, with like the contact dermatitis, poison ivy, poison oak, you're not going to the doctor for that. You just put the calamine lotion or whatever and it goes away. Estimated it costs millions, and factors determine who reacts to which substances is not known, maybe due to that HLA subtypes, as far as who really gets reactions to certain things versus who doesn't. Obviously, there's a genetic form of that. So, histopathology. Spongiosis is the edema of the epidermis. And when all this fluid goes in there, it separates the keratinocytes from one another. So they're being pulled apart from all the extra fluid that's going into that space. Spongiosis may be slight, barely perceptible microscopically, or so massive that it's evident clinically as a blister. Spongiotic dermatitis also associated with perivascular inflammation, and the infiltrate is mainly lymphocytes, but some eosinophils can also get in there as well. Remember, this is an allergic reaction, so eosinophils will be present because it's an allergic reaction. So you can see here, all of this stuff is just like a sponge. It got swelled up from all the fluid that's got into that area, from the localized swelling, the inflammation. That is what contact dermatitis looks like. So all this marked spongiosis, all in there. Again, all those cells should be nice, tightly packed, but they're being spread apart. Looks like a sponge because it's soaking up fluid, and it spreads apart all those keratinocytes. Again, it's your delayed type 4 hypersensitivity reaction is what a lot of these allergic contact dermatitises are going to be. We have an induction phase where the allergen binds to a protein, creation of a foreign protein. Here are the Langerhans cells again. That's the immunity function of our skin. And they engulf the complex, partially degrade it, bring it to the lymph nodes, present the antigen fragments so that we know what we're fighting against. T cell receptors bind, T cells clone themselves. However, the first exposure may not yield a reaction, but now you're primed for it. And then the next time you get exposed, you may have a full-blown reaction. So now we're sensitized again. If you get exposed again, then you have that hyper responsiveness because we're already primed for it. Remember, this is the delayed type. So 24 to 48 hours to present. Takes some time for all these things to happen. That's why it's a delayed hypersensitivity reaction. Again, here's what it looks like. Rust dermatitis, your poison ivy, poison oak, nickel allergy, soaps and detergents. Whenever someone comes into a reaction like this, you want to ask them, did you change your detergent recently? Are you using a new clothes washing detergent? Because remember, if you change your detergent and you wash your bed sheets with it, what are you sleeping on every single night? You're re-irritating yourself if you're allergic to the detergent. So those are some of the questions you want to ask. Any changes in detergent? Because they're going to be wearing that stuff all the time. It's like I said, cortisol, give it for everything. Now the joke with derm is that if it's dry, get it wet. If it's wet, get it dry. That's how you treat derm. Because that's pretty much what you have to do. Okay, paniculitis. This is the pattern. The example is erythema nodosum. This is paniculitis. What's special about this is that it usually affects their subcutaneous fat. This is where a lot of this is going to happen. Subcutaneous fat layer. So most common form of paniculitis, most common in the anterior lower extremities. So on the shin areas where you're going to see these lesions. The lesions can vary, typically of a dozen or more. Very, very poor demarcation because of how deep they are. This is in the subcutaneous layer. You have to go through the epidermis, the dermal layer, the dermis. Then you get to the subcutaneous layer. That's why they're not well demarcated, because the infection, the inflammatory process is too deep in the skin. You don't have those nice demarcated lines. If you have an infection in the epidermal layer, it's so superficial, then you get those nice clear borders. So if you have nice clear borders on the infection, it's usually an epidermal, maybe some dermal involvement. But this type of thing with paniculitis, subcutaneous fat is where the problem is. That's why they look like deep bruises. The red and the black, these little lesions everywhere, they kind of look like bruises, but they're not. It's deep from the subcutaneous fat. Etiology, more women than men. Usually an end result of inflammation, so strep, history of sulfonamides, oral contraceptives can cause this, and IBD, inflammatory bowel disorder or disease, can do this as well. So this is what's going on. It's all in the subcutaneous layer. Involves inflammation of the fat under the skin, subcutaneous. Okay. Now, when it comes to the type, we classify it between two different ways. Does it affect the septum of the fat cells, so the place in between? Or is it affecting the actual lobe of the fat itself? So is the lobe of the fat the problem, or is it the space in between each cell, adipose cell, the septum? So, again, inflammation occurs in septal divisions between fat compartments. Septa thicken, can become fibrotic, depending on the infiltrate and the duration of the reaction. We get lymphocytes, histiocytes, granulocytes, all go into this area. Then we lead to fat necrosis of the subcutaneous lobules. Okay. So again, it's another believed to be a type 4 hypersensitivity reaction involving the fat, subcutaneous layer of the skin. May involve some immune complex deposition as well. What type of reaction is an immune complex? 3. Okay. Okay, presentations. Most common, anterior lower extremity. Other sites, thighs, extensor forearms, and the trunk, which is relatively rare. They will persist as long as that triggering stimuli is present. So again, going through your history, figure out what were they doing before this happened. What was going on? What were they doing? Another interesting thing about this erythema nodosum, It may be the presenting sign for sarcoidosis. We mention sarcoid a lot. We don't really get into it, but we kind of mention it throughout different things. Oh, sarcoid would do this, sarcoid would do this. You will learn all about sarcoidosis, don't worry. But this is one of the causes we have to kind of get through. The next one is nodular dermatitis. This is cutaneous sarcoidosis. So we're going to talk about sarcoid again because it pops up with these dermatologic manifestations. The sarcoid itself has different reasons for its causing. These are sequelae, or these things only pop up as a result of an underlying sarcoid disease. So nodular dermatitis. This is nodular dermatitis. Nasal folds is a big area where these are going to show up, in the nasal folds. Hugely varied clinical spectrum, from mild asymptomatic disease all the way to life-threatening lung disease. Often present on the face, nasal folds. These nodular granulomas can occur in the pulmonary tree and other viscera. So all these nodules, you're breathing in and out through your nose. Those cells go into your lungs and they can invade your lungs. So you have those granulomas in the lungs. These are all different signs and symptoms of these issues. The granulomas, you can see here, they kind of go along the lung there. And you can see them here on the x-ray, these granulomas. More common in young adults, increased incidence in African American population. Mycobacterium species, especially Mycobacterium tuberculosis, can cause these granulomas as well. Histoplasma can do it. Viruses, maybe some genetics as well, that will cause this granulomas to form. So, what is going on? We have these granulomas form, and they're present in the dermis. They're non-caseating without central coagulation necrosis, so we're talking about central coagulation necrosis. What color would we be talking about if we said they had necrosis in the center? Pale, dusky colored center. That's indicative of necrosis. There is no necrosis here. That's why the lesion stays solid the whole time. They don't turn to those target lesions because there's no necrosis going on. Obviously, T-cell reaction can occur. Antigens induce T cells, which give out cytokines to bring macrophages in. CD4 helper cells direct the immune response, and the CD8 cells limit the extent of the response. So the CD8 suppressor kind of calms it down. The CD4 will kind of get the immune response going. So the CD8 kind of acts like a control, so the response doesn't go abnormal. Presentations. One of them is called Lofgren syndrome. On the chest x-ray, bilateral pulmonary hilar lymphadenopathy. That's what this is. Hilar lymphadenopathy. Fever, arthralgias. Here's your acute erythema nodosum. Again, indicative of sarcoid. The next one it can present at is called lupus pernio. This is your nasal rim sarcoid. All of those granulomas around the nasal fold and the nose. Okay, that's lupus pernio. Bead-like papules in the rims of the nares. If they have that, tracheal, bronchial tree, or lung parenchyma involvement. If they already have these granulomas, assume they have problems inside the lungs as well. Also, this is often a diagnosis of exclusion. What does that mean? A diagnosis of exclusion. We've ruled everything else out. We don't know what you have. We'll call it this. We don't, yes?
So if you have the granulomas like in the nose, then you know it's in the lungs?
Probably yes. So we're going to be, obviously, chest x-ray, bone x-rays show sarcoid, you got to confirm it. But you've looked at everything else, what else it could be, allergic reactions, this and that, everything comes back negative. So it's probably going to be this if you've ruled everything out. Another diagnosis of exclusion is like fibromyalgia. You've ruled out every other cause for why they're having their pain. We don't know why. We classify fibromyalgia, the diagnosis of exclusion. We don't know. We've ruled out everything else. This is the last thing it could be. The last one is folliculitis and perifolliculitis. Okay, this is your acnes. They present as follicle-based comedomes, which are like the whiteheads or blackheads, inflammatory papules, pustules on the face, neck, chest, or back. Teenagers are stereotypically affected, but neonatal and adult acne can also occur. Disfiguring nodulocystic acne with severe scarring will not occur before puberty. So they won't get the pock marks on the face from just picking at the acne and whatnot. That stuff won't happen until after puberty because you need what? What's the main cause of the puberty, of the acne? Anyone know? Which hormone? Close. Just androgens, just your androgens that form. Testosterone is the weaker ones. That causes the acne. That's why neonates, when they're born, sometimes they're born with acne because one of the triggers to start the parturition, the delivery process, is the baby starts creating androgens, which means they're fully developed and ready to go. When they start developing androgens, that starts the birthing process, that whole thing to start. But then obviously the androgens can cause acne in the neonates as well. So acne vulgaris, numerous inflamed pustules and papules with central black plugs, often open comedomes or blackheads. They're black because the dirt and oil, whatever, got trapped in there, making it black. Whiteheads are filled with white blood cells, pus essentially. But the whiteheads are closed comedomes. Blackheads are open. Those are open to the environment. Okay? So a comedomal acne manifests widespread follicle, dense keratin plug within the hole inside. So again, open comedome, the orifice is open. In a closed one, the orifice is normal, but the follicle is plugged below the skin surface. Secondary inflammatory changes occur because of these plugged follicular units. That gives us the inflammatory process now. That gives you the redness around the acne. Neutrophils may accompany the keratinous plug within the canal, creating that pustular lesion. Again, white blood cells cause the whiteheads to happen. Inflammatory acne lesions are a consequence of follicles that have ruptured, spilled debris into the perifollicular dermis. When that happens, dense inflammatory reaction. That's why you don't pop zits. Because when you do that, you cause an inflammatory reaction around the area, and you can spread and make the acne worse because you're causing these acute inflammatory responses every time you do that. So what actually causes these acne lesions to develop? First thing, the pore is plugged by keratin, skin cells. Okay. Then it gets plugged up, we get sebum production, that's your oil. Then this creates a perfect environment for Cutibacterium acnes. That is the actual bug that causes acne. Used to be called Propionibacterium, but now it's Cutibacterium. I don't know why the name changed, but maybe they found a different class. I don't know. So anyway, C. acnes is the bug that causes acne, and then that secondary inflammatory process that comes from pops, whatever. Okay, being dirty does not cause acne, and vigorous and frequent cleansing does not improve the condition. So all acnes are different. Some people go crazy with like the face washes and they dry their skin out way too much. and they actually get rid of the good bacteria, so the C. acnes can actually kind of go unopposed, making things worse. So if you get into derm, you'll learn about all that fun stuff. So let's see what's going on now. The keratinocytes become sticky and fail to slough our skin cells. That leads to that follicular plugging. Increased sebum production is a food source for the C. acnes, and we get bacterial overgrowth. All that sebum, that oil, degrades to lipids and free fatty acids, and that causes expansion of that canal, so it's widening that pore, making it bigger. The C. acnes in that area recruits neutrophils, and that causes pustule formation. That gives you that pus inside the acne. Neutrophilic enzymes weaken the follicle wall, leading to rupture. And we get a large quantity of all these inflammatory reactants that are in that little area now spread to surrounding tissues. Because of this secondary inflammatory response, more lymphocytes, more macrophages come to the area. Now this comedome is transformed into an inflamed papule or a pustule or a nodule of acne. So the nodular form of acne is obviously the worst form. And then follicle rupture, that secondary reaction, profound scarring. Again, don't pop your zits because that's what's going to cause. So here's a kind of picture kind of showing you. First we have this early comedome. You get keratin kind of sloughing and falling into that little pore, plugging up that pore. Then because we're plugged up, we get accumulation of sebum. All the oil builds up in that area. You get overgrowth of the bacteria, weakened walls, starts to swell up, and then eventually the walls are so thin they break, spreading inflammation to the next surrounding area of the skin. So that's how acne forms and how it can spread to different areas as well. So here's your neonate manifestations. Again, androgens from the maternal side. Sorry about that. I said before, I thought it was androgens do cause the delivery of the baby, but maternal androgens can cause the acne for the baby. They still get C. acnes overgrowth. Acne continues until maternal androgens are cleared out of their system and all their sebaceous glands go back to normal size. Puberty. Obviously, androgens are here, stimulate enlargement of your sebaceous glands, getting all that stuff going. Onset can be gradual or rapid. And severity will range from, are they primarily comedomes? Do you have some inflammatory thing going on with papules and pustules? Highly inflammatory, now we're getting nodules, and then scarring from there. So here are some different manifestations of acne vulgaris. You can see how wide those ones are. These are all open comedomes. All those blackheads, those are wide pores, trapping dirt, and then some of these are closed. They have the pus inside. So that's acne vulgaris. Clinical manifestations may present as a component of a syndrome. So Stein-Leventhal syndrome is really PCOS. But because of all the hormonal changes that are going on with PCOS, they get a lot of androgens forming. Also, this last one is Sapho syndrome. Synovitis, here's your acne. You'll get this a lot more with derm. Don't worry about it for me. But again, just know that Sapho syndrome can cause acne to form as well. So here's your classification. You have your mild acne, few to several papules, less than 10, no nodules. For moderate acne, 10 to 40 pustules or papules, some nodules, not very much. But the severe acne, many, many nodules. You can see how wide these areas are for the acne. Those are the nodular cysts for severe acne. And I think we're done. Okay. So tomorrow we'll do our review, and on Friday I'll see you got your schedule switch so that I'm supposed to be at 10 o'clock on Friday, but I'll see if I can switch up the schedule. So look out for the schedule in Outlook for changes. Tomorrow we'll do a review. Next Wednesday is your exam. Just on pulmoderm, this is it, these 2 lectures. Okay, you guys are done. I will see you guys Thursday.